สวัสดีครับทุกท่านนะครับวันนี้ก็ซีเปิดทอล์กก็มาเจอกับท่านอีกครั้งหนึ่งนะฮะก็ในบรรยากาศพิเศษนะฮะเรามีแขกมีฝรั่งด้วยนะฮะก็เพราะฉะนั้นขออนุญาตปรับภาษานิดนึงนะฮะเราก็สวิตช์เป็นภาษาอังกฤษนะฮะสำหรับเช้านี้Good morning everybody today in the June 21st of 2021 today we have guest Dr. Ryan Loy and we have Dr. Wasin Kampira. They are family doctor from Hajai Hospital and Dr. Ryan is a training family medicine in USA. So today we will have a talk about the family medicine training in USA. So welcome Ajahn Ryan and Dr. Wasin. สวัสดีครับ
Good morning. Very glad to be here today.
Very good. So today we have to try to talk in English.
That's really hard for me.
A little bit, but okay. But you have to know that Thai people maybe sometimes not. We are very shy to talk in English, but okay, you have to try. Yeah. First, so we can start with talking about the. So can you introduce yourself first? Why you come? So now you're working in the Department of Family Medicine and Community Medicine in Suranari University, right? Ajahn Ryan.
Yes, I did my training in medical school training in Texas, and I did my family medicine residency training in Oklahoma, and then I worked for several years teaching at a family medicine residency in Texas. However, about 8 years ago, I came with my family here to Thailand. My wife is Thai, and so we moved over to Thailand, and now I'm working at Suranari University of Technology for their medical department.
Yeah. Can you explain a bit more in during your training in medicine? You train in Texas U or something, right?
So I did my in America. You have to do your undergraduate first, and then after you do your undergraduate, you do medical school. It's 4 years.
Yeah.
And then after medical school, you do residency or specialty. And so my specialty was family medicine. So I did 3 years of family medicine training after my medical school. And so my medical school was in Texas at the University of UT Southwestern, University of Texas Southwestern in Dallas, Texas. And then my residency was at St. Anthony's Hospital in Oklahoma City. This is a little further north of Dallas.
Because I know we have to talk about you. So I have a map of USA in front of me to see that where is the Oklahoma City or something.
Yes.
It's in the up north from Dallas, right?
It's north of Dallas, about 3 or 4 hours north of Dallas on the highway. So it's the capital city of Oklahoma State.
Oklahoma City, right? Tulsa. The city. Okay. Yes. Tell me a bit more. So you undergrad degree, what kind of bachelor degree you have before you enter to the medicine?
So I knew I was going to medical school, and so I did a biochemistry, a Bachelor of Science in Biochemistry, and that overlapped well with the prerequisites. You have to do certain classes to go to medical school. So biochemistry overlapped well, but you don't have to do a science degree before medical school. I had classmates who had done communications or business degrees. You still have to take some science classes to do the prerequisites to go to medical school, but you can do any degree you want. One of my classmates had majored in violin at Juilliard in the United States, and then played for the Hong Kong Symphony Orchestra for several years, and then she decided to go to medical school. So you can do whatever degree you want. You just have to go and take an upper level biology and upper level chemistry. You have to take several classes and then take an exam to go to medical school.
So in US it's very open for medical curriculum to.
It is. It's very competitive, but you don't. There's not one track. There's people who are older who have done other careers who go to medical school, and there's other people who are straight out of, like me. I was straight out of college doing a science degree.
So you straightforward, right?
Yes.
Yeah, I heard someone got a bachelor degree in history and then become to the medicine, right?
Oh yes.
Can do
now,
it.
You have to take your bachelor's degree in history, but also take like a biochemistry class and a physical chemistry class, and you have to take physics. So you have to take some special classes
before you can go to the medicine
degree. But yeah, but yes, you can do any degree you want. And some people don't even get a degree; they just do their prerequisites, and they can work out a deal to go to the medical school. But usually, you get some sort of degree before you go to medical school.
Oh, okay, interesting. It's quite different from Thailand. We have, what we say, we have only maybe one or few tab. Let's say few tab, and yes, yeah. It maybe right. It not open like that, but okay, maybe next time we can move a bit. So after you study medicine for next 4 years, right?
Yes.
And after that, you got MD. And
after that, you get your MD, but you usually can't get a medical license in a state yet until you've finished your intern year, which is your first year of residency. So almost everyone in the United States will get a residency degree also, but they have to at least do the 1 or 2 years of internship to get their medical license to practice medicine.
So after finish 4 years, you have to take 1 or 2 years to get medical license, right?
So you have your medical degree, but you can't get most states. Each state licenses doctors separately, and so every state has different rules. In Texas, you have to have 2 years of post medical school training to get a license. In Oklahoma, you just have to have 1 year, an internship year. And in some other states, just 1 year. But you have to do some sort of post-medical school training, usually an internship for 1 year. And that's the historical way that medicine was practiced in the United States. Everyone would go to medical school for, it used to be 3 years. Then people learned a lot more medical knowledge, so they made it 4 years. And then you do 1 year of internship, and then you're a doctor, a GP, general practice.
Yes.
And you go and you practice, and most doctors were GPs until about the 1950s and 60s. And then all of the residency programs had developed for all the different specialties, and the best, brightest wanted to do more training than 1 year. So they would all go and specialize. And so all of the general practice doctors thought this isn't good because it's very important to have good general practice doctors. But if everyone who's a good student becomes a specialist, we won't have any good general practice doctors. So they decided to form the residency for family medicine. That was to be the training, the specialty of general practice, being able to take care of everybody.
And you can please talk slowly because I can't. We maybe not, but I got most of them. So after you finish, you got MD, MD, and then you have to train for residency in some kind, and you got the license from the state, right?
Yes.
And in Oklahoma, it's 1 year before you can get the license at least.
So I got a license in Oklahoma after 1 year of residency, but I wasn't finished with my residency. I had to do 2 more years. But I could have left my residency and gone and practiced medicine. It was legal to do that, but I wanted to finish and become a full family medicine doctor.
Yes. So I have 2 questions. If when you don't have license, how you can practice? And second, in 1 year, after 1 year, you have examination to tell that you part the training something. It happened or not?
So for the first year, you have to have a training medical license. It means you can only practice medicine as part of as a student at a residency. Similar to medical students have a type of medical license to be able to work in the hospital and do things. But residents have a training medical license. And that's just for the first year. After the first year, in the United States, there's the USMLE scores, or the USMLE. In medical school, you just take 2 of them. There's USMLE 1, USMLE 2.
Yes.
And then during residency, you take the 3rd one. During your intern year, you take at the end of your intern year, you take the 3rd USMLE. And if you finish that and you finished and your residency will give you a graduation certificate for your first year. If you pass the USMLE and you have your internship graduation certificate, then you can apply for a full medical license. And so actually, after my first year, I could go and on the weekends when I didn't have any work at my residency, I would go and make a little extra money by working at a local emergency room. Because I had a full medical license, so I could go and I could fill in at a rural emergency room, get a little bit of extra experience, get a little bit of extra money, and get used to maybe working a little bit independently by myself, not always having a teacher there. So if I got in trouble, I could always call my teacher at my residency up and ask for help.
Very good, very good. So it cannot happen in your first year. It cannot happen.
It cannot happen in your first year. No.
Yes. Okay. It's quite good. So maybe our system maybe something look like that, but maybe some different. So it at the point that so you try to when you decide that you will go to family medicine. That the question for today.
So when I was in college, that was when I knew I was interested in going to medical school, but I didn't know what kind of medicine I wanted to do.
Yes.
But I met some doctors who did international missionary work, and they made medical work in like Africa or places like that. Yes. And I was really interested in doing that. It's a good way to serve God and to honor Him and to help other people. And so I was interested in doing that, but then I asked myself, well, what kind of medicine is most useful if I go help out in a little hospital in Africa, or which I've done before, or something like that? What would be the most useful residency program? And I thought about it. I was like, well, family medicine, because they teach you to do everything.
Yes.
You learn a little bit of everything.
Yeah.
That was my thought. I was like, well, I think family medicine is the most useful, most flexible, and useful work I would like to do.
So you have adventure mind, right? You have to want to explore something and go to many places. Like, yeah. And same with you, Dr. Wasin. What do you think? Why you decide to train? Why you decide to train in family medicine?
It's very different from USA because in Thailand we decide to train doctor of medicine when we finish high school level. So after I graduated from the university, I worked as an internist at Songkla Hospital.
Yes.
Do you know Thailand?
In the southern part of Thailand. Now you're in the southeast of Thailand, yeah, in Korat, right? And you Songkla in the south in Hat Yai, Songkla Hat Yai, in the border with Malaysia.
Yeah.
Okay.
But at this level, it's the same as USA. You have to practice internship for 1 year, then you have to move to the hospital that you assigned for 2 years. Then you can become a residency that any you want to be, yes, like internist or surgeon or something like that. But I decided to work in the rural hospital for 5 years. And you may know because you have been in Thailand for 8 years. In In 2019, they have a Thailand Primary Health Care Act. Health System Act. I don't know how to call it. It encourage the primary healthcare system in Thailand to produce a family physician to support the people. Increase the ratio of family doctor to 1 per 10,000 people in Thailand. So we have to finish this task in 10 years. That requires about 65,000 family doctor in Thailand in 10 years. So I have an opportunity to working and test the board exam. So I got the certificate of Thai Board of Family Physician.
Yeah.
But I did not. Yes, but I did not pass the residency program. In Thailand, you can get the diploma with something like this.
You mean in training?
In Thailand, correct? There's the residency track, and then there's the working track. You can work.
Yeah.
Become a family medicine doctor, which is actually how family medicine started in Thailand, in America. Initially, GPs who had worked for many years and developed their skills and their knowledge, they got together and formed the Family Medicine Association in America. And GPs who had practiced for a certain number of years and had experience could do a process where they would become family medicine doctors. And then they started opening residency programs to train the next generation. So that's similar to how family medicine started in the United States many years ago.
Yeah.
Right, and you know the ratio of family medicine doctor and people in US. You have some idea, roughly?
I actually don't. I don't know. I could look it up for you real quick.
Okay, it's okay. It's okay for let's say we plan for 10,000, right? That you said.
Yes.
It's okay. Or
planning for one per 10,000. That's
it's very low, or maybe.
I'm not sure actually. Let's see here. I actually don't know the answer to that. Because the issue is that there are it depends on the area you're in. If you're in a major city, you can have one family physician for several hundred people. I know there's one doctor for every 600 people, I think, in like say Washington D.C. But then in other areas there might not be a family physician, but for thousands, there might be thousands or tens of thousands of people per family physician. So I don't know the answer to that question. I'd have to research it.
Yeah. Okay, thank you. So
I think 10,000 is it's a good goal. Maybe not stop there, but 1 per 10,000 I think is a good goal to start off with.
Yeah.
Yes, very good. So it that like you said, in the distribution of physician, it come to the urban or the city more than the rural, right? It
depends on where you're at, for sure. Now, in some cities, if you're in a poor area or an inner city, there might be a very low percentage of physicians per patient. But then you get to richer areas, you might have a higher percentage. And then if you go out in the country, in certain areas in the country, you might have a large number of doctors because it's a nice place to live. And it's conveniently next to a city. In other rural areas, you'll have very few doctors.
So is it maybe it's look like insane question, but you have rural area in US? You still have that?
We have a very large amount of land in the United States. Large numbers of people are moving into the cities. The land amount still stays the same, and so there's still people living out in the rural areas, way away from major cities. Yes.
Yeah. At Oklahoma is really big. It's a state, right?
Not that many people total, and most of the people live in Oklahoma City or Tulsa. or in the
Tosa, yeah, Tosa, I see Tosa.
Yeah. There's
But it's
areas
more-
where I looked at some places when I got out of residency. I was looking for jobs, and I thought maybe I would work in a rural area in Oklahoma. And so I looked at some areas, and I could drive west in Oklahoma for hours, and you might see one or two little towns, and then there'll be a little clinic or a little hospital, maybe 3 or 4 or 5 hours from the major city, and that's on a highway, so it's a long distance, and they need doctors out there too, but there aren't very many. There's not that many people either, but there's people there, and the people need doctors, and so it can be difficult to get doctors to go out to rural areas. Another reason why we train a lot of family medicine doctors, because they are equipped to take care of people in rural areas for all of their different medical problems. There's no specialists available.
Yeah, right. I saw the Wichita Fall and Amarillo, maybe, I don't know, in the city in up north of the
Amarillo is way out there, but it's a major city. It has doctors, but if you go into the country around Amarillo, it's a lot harder. I mean, there's a lot of farmers out there who don't have a lot of medical care. It's hard to get doctors. One of my colleagues who ran the residency program that I worked at, when he was younger, he used to work out in Spearman, Texas, which is far north of Amarillo in the we call the Panhandle, the part of Texas that sticks up, and it's very rural out there, and it's hours and hours to get to any sort of city, even a moderate-sized city. You have to drive for hours and hours, and so they have to have little hospitals out there that can do surgeries and deliver babies and stuff, because people can't go hours and hours to go deliver their baby. So you have to have some rural family medicine doctors out there to take care of people.
Okay. So let's move to next question. So we want to know how you train family medicine in US. That the how you let them go to the house of the patient or something, or you have a project with them or some kind of that. We want to know about that. Can you tell me about this?
The family medicine residency programs are very comprehensive. During your first year, you start off, you have what we call a continuity clinic. Every resident does, and you get used to seeing your own patients. Every resident's assigned every intern and resident is assigned their own day. So they might have 2 half clinics a week. I might work on on Tuesday morning, and Thursday afternoon might be my clinics for the week. And they would try and give me the same patients every time they go in. Those are my patients as a student. And so if they come another day, they can see one of my partners, but they try to always schedule the same patients with me, and then the other patients with the other students. And so we get used to having our own patients for the full 3 years. I'll have a patient I see for 3 years during my training, and that's in the outpatient clinic. So we have the outpatient continuity clinic. It's called the continuity clinic for 3 years, your entire residency. It doesn't matter what rotation you're doing. You always have to go to clinic as well to get used to it, because that's a large part of your work once you get out of a residency program. So you have outpatient continuity clinic. Then you have your inpatient rotations, and you do a lot of those your intern year to get you used to doing it. So we do inpatient internal medicine. We do inpatient. We'll do some inpatient rotations with the surgeons and all the different specialties. But a lot of internal medicine service rotations, especially the first year. But all 3 years you do rotations, and you do obstetrics rotations. So we have every year you go and deliver babies and learn to do C-sections as well. In my residency program, not all residency programs teach their doctors to do C-sections in family medicine, but if the ones that are trying to train rural doctors, sometimes they have to be able to do that. If they're in a very rural area, there's not enough OB-GYNs to do the C-sections. Then the family medicine doctors will take turns doing those also. if you're hours and hours away from a referral hospital, you have to do them at your little hospital. So we train to do those. We train to deliver babies. We have our continuity deliveries too. That means that we have in our continuity clinic, we have a few prenatal patients that we see, and we get them when they become pregnant. We do all of their prenatal care they're our patients. We see them back again and again. We do their ultrasounds. We learn to do ultrasounds. We learn to do their lab work to detect complications to the pregnancy, whether if they develop high blood pressure or preeclampsia, or if they develop other complications. We learn to deal with those. And then when they go into the hospital, it doesn't matter when they're in labor. It doesn't matter what rotation I'm on. They call me and say, you need to come over here and deliver the baby. Even if I'm rounding on patients in the internal medicine ward, or once I was doing my pediatrics rotation and we were doing rounds, and I got a call and I told my attending, the pediatrician, I said, I've got to go deliver a baby. I'll be back as soon as I can. And so I had to run to the other hospital where my patient was in labor and do the delivery and take care of the baby afterward. And then I could go back and finish my pediatrics rotation that day. So they're trying to train the doctors to be able to be the traditional general practice doctor who has a clinic, but also sees their patients in the emergency room and in the hospital. And then also can deliver babies and take care of complications with those.
Yeah. And I'm a general surgeon, so I would say that your work is maybe more complicated than my. But I can say that it's not surgical problem, and it's your bye. But I think you cannot say that because
Now,
you have to do
It's a complicated case.
very wide space. Yeah. Right. Sorry, I missed the word. So, what did you say?
So if there's a complicated case, then we'll often have to refer or get a specialist help. And many family medicine doctors in the United States do not end up doing all of those things, but the residency training is trying to prepare them to be able to.
I see.
So most family medicine doctors just work in a clinic. They don't see patients in the hospital anymore. They don't go to the emergency room, and they do not deliver babies. But all family medicine residency programs in the United States teach their doctors to do those things, because some of them will go out and work in rural areas or areas that are underserved, and they'll be able to do those things if they need to. If there's a need in the community for the family medicine doctors to be able to do those things, then they can. But my residency program was specifically geared to try and train doctors who could work in rural areas. And so it had a little more comprehensive training than even a lot of the other family medicine residency programs.
Yes, great. Dr. Watson, do you have any question for training? How to train in America?
Yeah, that sounds very interesting. I think the family medicine emphasis on continuity care, right?
Yes.
Yes. I have some question about the training program in the US. How many years you have to looking for inpatient care?
How many years do you have to do inpatient care during residency program?
Yes.
So it depends on the residency. I cannot remember the Board of Family Medicine requirements off the top of my head, but I want to say I would guess at least 3 or 4 months of inpatient internal medicine training. That's my guess. I'm not certain. I did a lot more than that. Our residency program, you got more like 6 to 8 months. But I believe it's probably 3 or 4 months of inpatient medicine. You have to do at least 2 months of obstetrics and gynecology training. You have to do at least 1 month or maybe 2 months of general surgery. You have to do 1 month of critical care. There's a whole range. There's requirements for a lot of things. You have to do a month of sports medicine. You have to do a month of urology. You have to do, and so we'll go and we do rotations with all the different specialists In each specialist, the specialists we work with would know we're family medicine residents, and so they would try and tailor our experience to not just see all of the really, really complicated stuff they deal with that always goes to a referral, but to deal with the things that we'll see every day. And so when we go to the urologist's office, they would do a lot of working with us on how to take care of prostate cancer screening and diagnosis, how to deal with benign prostatic hyperplasia and urinary issues like that. So they would try and tailor our experience to be able to take care of the basic things in their specialty, but also be able to recognize unusual things so we can refer them to the specialist.
Yes,
They have some question from the listener. They said, what are job of family medicine in US? Do they do the gynae, OBGYN, OPD surgery or prevention? That you said it. You have to do all, right? Can you answer this?
Jobs in the United States, most family medicine doctor jobs are for outpatient clinic work. But in their clinics, they will take care of adults, they'll take care of men and women, and they'll take care of children. Take care of elderly people and middle-aged. They'll take care of sports injuries. They take care of all kinds of people, but usually in the outpatient clinic for most family medicine doctors. That's not how it used to be. Most family medicine doctors used to go to the hospital too to take care of their patients, but it's so crazy now. It's hard from a time standpoint to see enough patients in clinic and be able to run over to the hospital to take care of patients there also. So most family medicine doctors take care of patients in the clinic, but in their clinic, they do things like pap smears, and they'll do things like birth control. They'll do things like well child checks and immunizations. Yes. They will do things like high blood pressure, diabetes screening, and then once they diagnose them, they manage them. As people get older, they'll start doing things like cancer screenings, colon cancer, breast cancer, do all health maintenance sort of things. And they'll do minor procedures, minor dermatology surgery, like removing very superficial like basal cell cancer or freezing off things on the skin. They'll do things you can do in a clinic, and they do some very minor kind of skin surgeries, that sort of thing. Some of them will have a procedure clinic too, where they do things like endoscopy, though usually it's gastroenterologist doctors and surgeons who do those. But many family medicine doctors have learned to do, and when I was in the United States, I would do EGDs and colonoscopies as well in the clinic. We would have a procedure room and we would do things like that in the clinic. So you try and provide comprehensive screening care and health maintenance and taking care of chronic medical problems as well in your clinic.
Yeah.
But not every family medicine doctor does that. Yeah. My brother is a family medicine doctor, and he does only emergency room work. He cannot work in a large trauma center because you have to be an emergency medicine physician for that. But he works in a rural emergency room as a family medicine doctor, and he provides emergency room care. And that works well for his family, for his schedule, and so he does that. Yeah. There are other family medicine doctors I work with when I'm in the United States who do only internal medicine in the hospital, inpatient. They are hospitalists. It's a new field. And usually internal medicine doctors and family medicine doctors are most of the hospitalists in the United States. So you can there's a variety of opportunities for family medicine doctors in the United States. Most do not deliver babies, but there are still quite a few in rural areas that still do.
Yeah. Someone asked about the income of the family doctor. Is it get well enough?
So it depends on what you do. If you only work in a clinic and you don't do any procedures in your clinic, then you will get paid less than most other doctors. So the lowest paid physicians in the United States are things like family medicine and pediatrics. If they're only seeing patients in the clinic and they're not doing any procedures, because procedures pay better. There's more money to make when you do procedures than just seeing patients, even though seeing patients and using your brain to do a diagnosis is many times harder than doing a procedure. And it can take more time too if you're doing a good job, but it doesn't get paid very well. So it depends. I know family medicine doctors who make about, they'll make maybe a third or a fourth of what a surgeon will make in the United States, or maybe even less than that. So maybe 1/4, maybe 1/5 of what a surgeon will make. There's some family medicine doctors who do that. And I know other family medicine doctors who work in a rural area and they do everything, and they work hard, they work long hours, and they'll make more than a general surgeon. So because they do a lot of stuff. They do endoscopies, they run the emergency room, they see patients in the hospital, they do deliveries and C-sections, minor surgeries like appendectomies, just things they learn to do. And they they'll do echocardiograms, and they'll do stress tests, and so but they work really hard. They work a long hours. They get called in the middle of the night all the time, but then they make a lot of money. And so it's what you want to do and how much you want to work.
Okay, I understand. In Thailand, I have one thing that show that you are family medicine doctor, and I don't know, is home healthcare. This happen in US. Do you have home healthcare system or something?
It used to be more common. And so all family medicine doctors, when you're in residency, you have to do home visits. And so we would go out to our patients' homes. You only have to do a few, but you have to go out and do an assessment in their home. Usually it's a home safety assessment, or if it's a patient that can't get to the doctor very easily because of mobility issues or transportation issues. And so the residency will have a list of patients that need home visits. And so each family medicine resident will have to do at least, I think, 2 or 3 home visits. It's not very many during their residency. And so I did that. And then when I was attending teaching, I would go out and do home visits with the residents and go out and see patients in their homes. And we would do a safety assessment, and we would give recommendations for, maybe you should move these rugs are going to cause you to trip, or it'd be good to get some bars in some of the grab bars in the kitchen or in the bathroom, so that so that the older person doesn't fall and break something. And we just do a safety assessment, and also go and check their medicines and see if they have the right medicines and if they have them organized correctly. And so we would do some home visits. There are a few. Very few, but there are a few family medicine doctors that make their living doing home visits.
Oh, I see.
Usually it's a cash-based system where they won't accept insurance. But if someone wants a doctor to come out to their house, we call it a concierge service. And they don't necessarily charge a lot, but they don't accept insurance. You have to pay them cash. And so there are doctors who will go and drive out to your house and see you and give you prescriptions, and they'll bring along some equipment so they can do basic, like maybe steroid injections in the knees, and or some basic dermatologic, maybe a little freeze gun or something, so they can freeze off little things on your skin. I would just do whatever they can, and they have their blood pressure cuff, and they might even have some equipment to draw blood or something, and they'll go out and see patients in their homes as a business. And that's what they do, and it provides a service for people. It's pretty uncommon. I know of one doctor who was doing it in town where I was in the United States, and he was making a decent living, and he enjoyed it. He enjoyed driving out and seeing people at their houses.
Very good. Okay, Dr. Wasin, you have any question for him?
I have some question for Ajahn Ran. Maybe you can answer the question. In the US, what is the role of family doctor in dealing with COVID-19 pandemic?
COVID-19 pandemic. So the family medicine doctors form probably a third, maybe, of hospitalists, and hospitalists are the ones taking care of the patients in the hospital. And so that's one place that family medicine was helping with we were taking care of the COVID patients who were hospitalized. And when I was stuck in the United States, I was planning on coming. I travel back to the United States regularly to visit my family and to keep up my credentials and my license there. And so I was planning on coming back to the United States last July or last June. And then COVID hit, and I was not able to get back for over a year. So it wasn't until earlier this spring that I got back to Thailand. So while I was in America, there was two ways that family medicine doctors were helping take care of patients during COVID. Number one, I was doing this. I was working with the hospital service, taking care of COVID patients in the hospital.
Yes.
And so we were trying to keep up with the newest strategies of taking care of them. We were monitoring their oxygen. There were not enough lung doctors. Were overwhelmed. The pulmonologists were overwhelmed. And so we would not consult the pulmonologists on the COVID patients at all, or the infectious disease doctor, unless it was someone who needed to be put on the ventilator. And so the internal medicine and family medicine doctors were the ones taking care of most of the COVID patients, where I was in the United States. We also do emergency room work, especially in rural emergency rooms. And so we were there to diagnose patients with COVID and see who needed to be transported to another hospital or who could go home and be monitored from home. And so that's one way that family medicine helped. The other way is through telemedicine. See, a lot of patients couldn't go in to see their doctors. A lot of doctors' offices closed early on in the pandemic, and they were closed. A lot of the doctors are older. They had a good chance of getting really sick and dying. A lot of doctors did die from COVID. And so especially older doctors had to close down their clinic, and most outpatient clinics closed down for at least a couple of months. And so I started doing, and a lot of other family medicine doctors and emergency room doctors started doing a lot of telemedicine to take care of patients who couldn't get in to see a doctor. And we were refilling chronic medications. We were managing chronic medications for a while. Telemedicine doesn't usually do that. But for the first few months, you had to have someone take care of these patients. So we did a lot of telemedicine for the first few months of the pandemic until things opened back up.
Okay, thank you. Maybe the last question. Someone's Dr. Usiri said, in your opinion, what are the difference between Thai and US family training? What are your suggestions for improvement? That is a good question. Maybe we quote with this question. Okay, can you answer this?
The thing that I've seen, and I have to say, I've not had a lot of experience with family medicine training in Thailand. There's a program at Maharat Hospital, but our university does not have yet. So so I have to go off what I've heard about Thai family medicine, but my understanding is that Thai family medicine doesn't always have this idea of a good continuity clinic, though I think that may be changing. But a lot of the programs are not set up for a continuity clinic throughout the entire time of the residency. And I think that was something that was very beneficial in the United States. And it really sets the tone for how you want doctors to think about their career, that they are the primary care physician for their patients. They're not just someone that the patients are coming to for this one particular problem or this one particular problem, that they have to have ownership of the patient. That even when the patient goes to see a specialist, the family medicine doctor is their primary care doctor to help coordinate their care between all their different specialists, to help communicate to the patient, and to take ownership for the patient, and not just say, well, they're being taken care of by surgery or by the cardiologist or by whatever. Your patients, and you have continuity of care. You're going to take care of them when they're younger. When they get older, you're going to take care of them. If they go to the hospital, you may not go to the hospital. Like I said, some aren't doing that in the United States, but if you have an opportunity to, or at least to follow up for their care after the hospitalization, and to make sure that they're on all the right medicines, and to make sure that all the different doctors are talking to each other, which doesn't always happen. If they have many different specialists, the specialists may not talk to each other. And so you act as a coordinator of all this, your patient's care. And so I think that's something that we don't always do perfectly in training in the United States, but I think it's something that Thailand can work on also to work on that continuity of care and that patient ownership.
Yeah. Yes, very good. You read the point of the ownership of the patient. That's maybe today is maybe difficult, and let's say difficult for especially in some subspecialty. They try to treat the disease, not the patient, right? Sometimes, right?
Yes.
Okay. Yes, very good. So Dr. Wasin, you have any question or something to share?
No, is that
Yeah, I think we have a very good discussion and the time come is okay. So thank you อาจารย์ไรอันมากนะขอบคุณครับนะแล้ว
ยินดีครับอะไรครับ
ครับ see you next time นะขอบคุณทุกท่านและขอบคุณผู้ฟังทุกคน
ครับครับ
โอเคขอบคุณบ๊ายบายสวัสดีครับไว้เจอกันครับ
ครับสวัสดีครับ
สวัสดีครับ โอเค thank you